So now we will be dealing with some of the questions and I will give you the detailed explanation of these questions. Now in the first question, if you see, this is the aorta, this is the aorta, this is the ascending, this is the ascending aorta, then this is the descending aorta, and these are the branches. We know that from the aorta we have a left subclavian artery, then we have a left common carotid artery, then we have a right brachiocephalic trunk which is divided into two parts, that is left common carotid artery, right common carotid artery, and right subclavian artery. And this part, this is pulmonary artery, and there is some shunt which is between ascending aorta and the pulmonary artery, and this shunt is actually the Davidson shunt, which is used as a palliative procedure in case of tetralogy of Fallot. So tetralogy of Fallot is so this is actually a Davidson shunt. There are different kinds of shunt in tetralogy of Fallot that we will see. Now, for understanding of the shunt, now in case of tetralogy of Fallot, what happen is that we have to understand this is our pulmonary artery, which is main pulmonary artery divided into left pulmonary artery and right pulmonary artery, and then we have an abdominal aorta, then it is going to the and forming the descending aorta. I am coloring this aorta with the red line. This is the aorta. Aorta is anterior, that means it is closer to the thorax. If we go from skin to the thorax, then first we'll encounter aorta, then we'll encounter pulmonary artery. Now in case of tetralogy of Fallot, we can have different shunt. One type of shunt that can be is the between right pulmonary artery and the ascending aorta. One can be between the left pulmonary artery and descending aorta. Okay, and the other that is in the picture, it can be between the ascending aorta and the main pulmonary artery. Now, this aorta, as we know, is divided into left subclavian artery, then left common carotid artery, and then right brachiocephalic trunk, which divides into right common carotid artery and right subclavian artery. This is right subclavian artery, this is right common carotid artery, this is right brachiocephalic trunk. Now, there can be a shunt between the right subclavian artery and main pulmonary artery. So these are the four kind of shunt that we see. The first shunt, that is between the right pulmonary artery and ascending aorta, this is known as Waterston shunt. It is not used nowadays but can be asked as an MCQ. Then the shunt between the left pulmonary artery and descending aorta, this is known as Pott shunt. It is also not used. So Waterston shunt and Pott shunt both are now not used, so but they can be asked in MCQ. Now the shunt between the ascending aorta and the main pulmonary artery, that is known as Davidson shunt, which is shown in this picture. And then there can be a shunt between the right subclavian artery and the main pulmonary artery. It is what is known as BT shunt, that is Blalock Taussig shunt, which is the main shunt used as a palliative treatment of tetralogy of Fallot. I am again repeating, Blalock toxic shunt is a shunt between the right subclavian artery and main pulmonary artery. So if you remember this diagram, you can easily know what is the shunt. Now, coming to this question, if you see this baby, I'm giving you a hint that this baby, after crying, develops cyanosis. So you all know that it is a cyanotic spell. So here, the basic aim of this question is not to help you to identify this question, but is to know what is cyanotic spell, how to treat the cyanotic spell, and what are the different findings that we see in the cyanotic spell. So that we'll see in a minute. Now, if we see, we have a left atrium, we have a left ventricle, then we have a right atrium, then we have a right ventricle. Now, in right ventricle, we have a pulmonary artery. Now, whenever there is a stenosis, now in case of tetralogy of Fallot, we know that there are four things. One is pulmonary artery stenosis, which is generally subinfundibular. So we have subinfundibular stenosis, then we have right ventricular hypertrophy, then we have a VSD, and then we have a overriding of the aorta. Overriding of aorta means that is aorta is taking blood from both right ventricle as well as left ventricle. Again, I'm again repeating, in tetralogy of Fallot, we have pulmonary artery stenosis, which is a subinfundibular stenosis, and that is not constant. It can increase or decrease. That is a dynamic stenosis. And then we have right ventricle hypertrophy, then we have a VSD, that is ventricular septal defect, and then we have a overriding of aorta, that is taking blood from both right ventricle and the left ventricle. Now, we all know that in this is the stenosis in the pulmonary artery. Whenever the stenosis increases, we all know that blood will flow from right ventricle to the left ventricle, and this will create what is known as right to left shunt and will lead to cyanosis. So generally, the baby does not have cyanosis, but there are a lot of theories that after crying or after pain, some theories also advocate that due to emotional stress, increased catecholamine secretion, they all can lead to the can increase the stenosis, subinfundibular stenosis of pulmonary artery. As I have already told that this stenosis is not static, it is a dynamic stenosis, that is, it is subjected to change. So all these conditions, that is crying, pain, emotional stress, and increased catecholamine can lead to increased stenosis. When the stenosis will increase, there will be less blood flowing from right ventricle to the pulmonary artery, and more blood will be flowing from right ventricle to the left ventricle. That is, now it has two implications. The first implication is, since there will be less blood from right ventricle to the pulmonary artery, the systolic murmur, that is the ejection systolic murmur that we see generally in tetralogy of Fallot, will decrease during this time, and the shunt, that is the blood from right ventricle to left ventricle, will increase, and thus the cyanosis will increase. This is known as cyanotic spell. This complete phenomenon is known as cyanotic spell. So what happens in cyanotic spell? Right to left shunt will increase. The murmur, or we can say the ejection systolic murmur, will decrease. This is very important because the blood flowing to pulmonary artery will decrease. And third, cyanosis will increase. So this is what is known as a cyanotic spell that I have tried to explain to you. Now, what is the treatment? What is the treatment part of this cyanotic spell? What you will do? Now, we know that this is your right ventricle, this is your left ventricle. It has aorta, and this has a pulmonary artery with the stenosis, which is a dynamic stenosis. Pulmonary artery. Now, We can do two things. First is we can decrease this stenosis, that is the pulmonary stenosis or the pulmonary spasm. Now it has been seen that beta blockers can decrease the spasm of pulmonary artery, and when the spasm of the pulmonary artery will decrease, the right to left shunt will decrease and more blood will start coming through the right ventricle. So now just the opposite of cyanotic spell will happen. Less blood will go from right ventricle to left ventricle, so there will be less shunting, so there will be less cyanosis, and more blood will be coming from right ventricle to the pulmonary artery, so ejection systolic murmur will increase. So beta blocker can be used for this purpose because they decrease the infundibular spasm. Two beta blockers can be used. One is esmolol, and other that you can use is propanol. Now the dose of esmolol is 0.5 mg per kg followed by 25 microgram per kg per minute, and the propanol dose is 0.1 mg per kg. Esmolol, as we all know, is a shortest acting beta blocker. Now why it is the shortest acting beta blocker? Because it has a esterase group. So non-specific esterase which is present in the RBC destroy these beta blocker within 5 to 10 minutes. So duration of action is just 10 minutes because this drug has ester linkage, and that is destroyed by the non-specific esterase by the RBC. So esmolol is the only beta blocker which is metabolized in the RBC and has the shortest half-life because of ester bond. And the second you can use is propanol. Also you can give fluid to the baby, because giving of the fluid will what happen, there will be more volume of fluid in the right atrium and more in the right ventricle, so due to which there will be enlargement in the right ventricle diameter, and it has been said due to which there will be some relief in the stenosis. So 15 to 30 ml per kg of fluid can be given. Fluid can be given. So these are the two things. One is the beta blocker that can reduce the spasm. Second is the fluid you can give. Third is, now if you can somehow, if you can increase the, if you cause constriction of aorta or you can increase the systemic vascular resistance, then that increased resistance will be transmitted to left ventricle, and that will decrease the amount of shunting from right ventricle to left ventricle, and that will decrease the cyanosis. So anything that increases aortic pressure or increase the SVR will result in decrease of the cyanosis by decreasing the shunting of blood from right ventricle to the left ventricle. So we can do what? Knee chest position. So a lot of children of tetralogy of Fallot, when after of doing some work develop cyanosis, they automatically come to this knee chest position, which increases the SVR and aorta pressure, and finally increases the left ventricle pressure and decreases the shunting of blood from right ventricle to the left ventricle. Also we can use a drug that is phenylephrine for this. Phenylephrine. So phenylephrine is a vasoconstriction, so it will increase the SVR and decrease the shunting. So how to use phenylephrine? Phenylephrine, alpha agonist. It can be used first in the form of bolus, and then it can be used as an infusion. The bolus dose of is 5 to 20 microgram per kg, but maximum dose that you can give is 500 microgram. And the infusion dose is 0.1 microgram per kg per minute. So this is, a lot of people also support giving of morphine. Now some of the guidelines and all the morphine is given. Why morphine is given is still a matter of debate. Some people say that anything which causes hyperpnea or increased respiratory rate or respiratory instability can cause spasm of infundibulum. and which can cause cyanotic spell. So morphine was basically given to sedate the patient, and after sedation, it was seen that there was partial relief in the spasm of the infundibulum. This was the reason. But there was a second side of this story, that morphine causes systemic decrease in systemic vascular resistance and also causes venodilation. So these things can precipitate cyanotic spell, and there are a lot of case report where it has been seen that morphine use has precipitated or has further deteriorated the cyanotic spell. The normal dose is 0.1 mg per kg IV. So it is still used, but a lot of the case report that are coming are saying that morphine can further worsen the cyanotic spell because it decreases the systemic vascular resistance as well as causes venodilation. Now, a lot of recently there was a case published in which 8-day baby who developed cyanotic spell was managed with a drug that is dexmedetomidine, which is alpha 2 agonist. So, and the dose they used was generally the dose of dexmedetomidine is we give a zero point 0.7 to 1.4 microgram per kg dose is given over 10 minutes, and then it is followed by zero point 0.7 to 1 microgram per kg per hour. But in this child, that is the 8-day baby who develops cyanotic spell, they haven't given the loading dose. Loading dose was not given, and they have just given the maintenance dose of zero point 0.2 microgram per kg per hour, and the baby responded very well. So now, for sedating purpose, the interest is shifting from the morphine towards the dexmedetomidine. So this was regarding the treatment of cyanotic spell. Also, one of the theories say that acidosis can worsen the cyanotic spell. Therefore, bicarbonate also has a role, and the dose is 1 to 2 milliequivalent per kg, because it has been seen that acidosis also worsens the cyanotic spell by increasing the infundibular spasm. So bicarbonate is the role. So in a nutshell, what all we can use knee chest compression, phenylephrine, volume bolus 15 to 30 ml per kg. Beta blockers can be used, then morphine can be used, although it's risky, which dexmedetomidine can be used, and in case of acidosis, bicarbonate can be used. Even ketamine has also been used in some of the cases. So this was regarding the treatment part of cyanotic spell. Now, identify the condition in this ECG. Now, I'm giving this ECG to, if you see this ECG, what on the first you see, if you see the R wave progression, normally what happens, you have to understand something. For example, if this is a vector A, and you are measuring this vector from here, then you can measure only this much portion of the vector. Now the same vector, if you are measuring from here, then you can able to measure this much part of the complete part of the vector. Now third, if you measure this vector from here, then you can measure the complete magnitude of the vector as well as your direction is in the same line. As we know that vector has a magnitude and a direction. So if any vector is measured in its same line, then the magnitude is maximum and the direction is value is also maximum. So we get the maximum value of that vector. So in the A case and in the B case and in the C case, in C case, the maximum magnitude of the vector will be noted because we are in the same line as the vector and we can measure the whole amplitude as well as the maximum angle of the vector, that is 180 degree. So now why I am telling you these things? There is a reason. If this is a person and this is sternum. Then this is V1, V2, then V3, V4, V5 and V6. The normal heart is like this. Now if V1 will try to measure the heart axis this, it will just measure this part. V2 will measure this part. Now the lead which will be in 180 degree to this, which is generally V5 or V6, will measure the maximum magnitude as well as maximum angle, that is 180 with this axis of the heart. So maximum R wave therefore is seen in V5 or V6. It can be present in V5 as well as V6. Why V5 or V6? It depends upon the person who has put the electrode. If electrode is placed just at 180 degree to the normal axis is V5, then R wave will be more in V5 as compared to R wave in V6. If the lead V5 is placed here and V6 is placed in the axis, then R will be more in V6 as compared to R in V5. Whatsoever be the reason, we all know that from going from V1 to V6, R wave increases. And the reason I have told you this, because we are able to measure the magnitude as well as the direction, the angle, as we move from V1 to V6. So this is the law of vector. So this is called as normal progression of the R wave. That is from V1 to V6 R wave progress. Now what when we say that there is an abnormal progression of the R waves? So abnormal progression, when we will say that there is abnormal progression of R waves, if R wave in V3 is less than R wave in V2, or R wave in V4 is less than R wave in V3, or R wave in V3 is less than 2 millimeter. These things will say that we have an abnormal progression of R wave, which can be seen in old MI, yeah, limb, incorrect limb placement, yeah, obesity. These are the conditions where you can see abnormal progression of the R waves. Now in this condition, what you are seeing, that this is the R wave, then it has become little larger, then it has become little larger, then it has become little larger, then more larger, and then so it is following the normal path R wave. But what you see that the R wave in V6 is, if we talk of in terms of small box, 5 small box, 10, 15, 20, 25 and more than 25. So R wave in V6 is more than 25 small box. And if we talk of S wave in V1, that is 5, 10, 15, 20, it is 20. So if we add both of them, what we see 45. So now before understanding or going further, we have to understand that left ventricle hypertrophy, what are the diagnostic criteria of left ventricle hypertrophy? So if R wave in V5 or R wave in V6, in whichever it is bigger, I have told you, is more than 25 millimeter, then we make a diagnosis of LVH. Or R wave in V5 or R wave in V6, in whomsoever which is big, we have to take that, plus S wave in V1 is more than 35 millimeter, then that is also an LVH. Now coming to the limb leads, if we take the limb leads, in AVL, if R wave is more than 11 millimeter, that makes diagnosis of LVH. And in AVF, if R wave is more than 20 millimeter, that makes diagnosis of LVH. So this you have to understand. Now, if along with LVH, you have T wave inversion plus ST segment depression in V5, V6, that is been known as strain pattern, because you can have two questions. One, patient has LVH, second LVH with strain pattern. So whenever you diagnose LVH, just look at the V5 and V6 ST segment and T wave. If there is ST segment depression, just like, and T wave inversion, just like they see here. ST segment depression, T wave inversion, ST segment depression, T wave inversion, ST segment depression, T wave. That means this is LVH. Diagnosis will be LVH with strain pattern. So there are high chances that they can ask you this LVH ECG with or without strain pattern. Okay. Coming to the second ECG. Now, it is one of the ECG that are high chances of coming in the NEET PG question. If you see this ECG, what you see in lead V1, you see this is a RBBB pattern. Whenever QRS complex is more than 3 small box, so whenever QRS complex is more than or equal to 3 small box, you should suspect bundle branch block. Now for right bundle branch block and left bundle, for right bundle branch block in V1 and V2, you will have a M pattern, or like this, you can have this pattern, you can have this pattern, or you can have this pattern. All these patterns will be taken positive, first thing. Second, you will have a deep S wave in lead V5 or V6 or 1 AVL, in any of them. If these criteria are met, then we'll call that patient has right bundle branch block. Similarly, in left bundle branch block, in lead V1 or V2, you will see a pattern like this. That is a very small R wave, very small R wave. Such small R waves are present that even you can think that there is no R wave and you can consider this as a Q wave. But if you look closely, this will be a very small R wave. That is a very small RS component is present in V1. And in V5, V6, lead 1 or AVL, you have a deep, you have a broad R waves. What are broad R waves? Broad R waves are like this. That is no Q waves, no R waves. These waves are called as a broad R waves. And absent Q waves in lead V5 and V6. We all know that Q waves are normally present in lead V5 and V6 because of the septal depolarization. So these leads will be absent. So Q waves will be absent in. So when now again I'm again repeating, whenever QRS is more than 3 small box, you should think of bundle branch block. In case of right bundle branch block, look in V1, V2, we have a M pattern which can be like this, and like this. And second point, deep S waves in V5 or V6 or 1 and AVL. In cases of the left bundle branch block, in V1 and V2, you will see this RS pattern where R wave will be so small that you can even mistook them to be a Q wave, and you can you will not able to appreciate that R wave. And then in V5, P6, 1 and AVL, you will see broad R wave. Broad R wave means waves like this. There will be no Q wave and no S waves, and also there will be absent Q wave. So in left bundle branch block, the septal depolarization is lost, therefore there is no Q wave in the V5 and V6. So this I have covered what is left bundle branch block, right bundle branch block. Now so in this case, you are very much clear that this patient has a right bundle branch block because QRS is more than 3 small box. Then you are seeing M pattern. Then you are seeing deep S waves in V6 and even V5 and even 1 and also in AVL. So this is right bundle branch block. Also, if we now will try to know the axis. For knowing axis, draw two lines. First is the one line lead 1 and other is the lead AVF. Note this is positive, this is negative, this is positive, this is negative. Now in lead 1 you have to, and in all the leads you have to connect, you have to calculate R minus S. If it comes to the positive, you have to plot it in the positive direction of that lead. If it R minus S comes negative, you have to plot it in the negative direction. For example, in this, if we see lead 1, R minus S comes to be negative because S is more. So R minus S comes to be negative, and therefore we have to plot it here. Now in case of lead AVF, you see we have R minus S slightly positive because R is more than the S. So it will be like this. So the axis is here. This is known as north-west axis or known as extreme axis. So now this person has RBBB plus northwest axis or extreme axis. Also what we see that this patient has in lead 1 there is a deep S wave. We have a Q wave in lead 3 and T wave inversion, that is known as S1, Q3 and T3, which is seen in pulmonary embolism. Now coming to the T wave inversion, we see in lead 3 we have two wave inversion, also in lead 2 we have T wave inversion, and from V1, V2, V3 and V4 we have T wave inversion. So where does all these findings taking to us? So for that we have to understand something. We have to understand ECG findings of pulmonary embolism. The most common ECG finding of pulmonary embolism is sinus tachycardia, which generally people forget. Secondly, S1, Q3, T3, that is S1 means deep S wave in lead 1 and Q3 means Q wave in lead 3 and T3 means T wave inversion in lead 3. Again I am repeating. S1 means in lead 1 there is a deep S wave, Q3 means there will be a Q wave in lead 3 and T3 means there will be T wave inversion in lead 3. Note earlier it was known as most specific finding of pulmonary embolism, but now neither it is a most sensitive, neither it is a most sensitive diagnosis of the pulmonary embolism. So S1, Q3, T3 is neither the most sensitive, neither the most specific finding of the pulmonary embolism. Third point, you will see right axis deviation. Fourth point, you can see right bundle branch block. Plus in right leads, that is V1 to V4, you see T wave inversion. Plus minus inferior leads, that is 2, 3 AVF, you see T wave inversion. Then you can see AFib, A flutter. Note in ICUs, AFib plus RBB, this is a very high chances of pulmonary embolism. Okay, then rest you will. So now in this case, what are the things that are positive? We had a S1, Q3, T3 pattern. We have a right axis deviation, that we have a extreme axis deviation. We had a right bundle branch block. We have V1 to V4 lead T wave inversion. Inferior leads T wave inversion. So there are high chances that this can be a lead, it can be a pulmonary embolism. Now for that we have to do D dimer and FDP. Also we have to do the Doppler of the lower limb, and for confirmation test is multi-detector CT angio pulmonary artery. This is the most sensitive test if asked. Multi-detector CT of pulmonary artery, it is MDCT of pulmonary artery. And but after, if you have suspicion on ECG, you will do D dimer FDP followed by Doppler ultrasound. Okay. So this was a case of pulmonary embolism. I hope it was clear. Now comment on this ECG. Comment on this step. Mm, so this is a JVP wave. This is a C wave and this is a V wave. So can you identify which is the disease? Yes, you may identify, but here my aim is to teach you JVP because one question will definitely come from JVP. Now we see that after C generally there is a descent which is known as X descent, which is absent in this particular case. So there is no X descent. And what because of which we are seeing a CV wave, combination wave. This is characteristically seen in tricuspid regurgitation. So this is actually JVP showing off TR, that is tricuspid regurgitation. How we'll see. Now we see that we have a A wave, then we have a C wave, then we have a V wave. So this is a A wave, this is a C wave, this is a V wave, this is the X descent, this is the Y descent. Now we have to know what are the causes. Now A wave is caused by because of the contraction of the atrium. Now when does atrium contract? We know that we have a right atrium, we have a right ventricle. So initial 70% of the ventricle is filled by the right atrium passively. That is, right atrium does not contract, and because of the gravity, 70% or some books say 65% of the right ventricle is filled. The next 30% of the right ventricle is filled by the contraction of the right atrium. So this A wave is actually telling us the contraction of the right atrium, because of which the last 30 to 35% of the right ventricle is filling. If we consider this A wave with the ECG, there is a P wave before it. That is, because of P wave there will be atrial depolation, and after that this will be the A wave, and then because of this A wave the left ventricle will be filled. The last part or the active part of the left ventricle is filled because of the atrial contraction. Now this A wave is actually showing atrial contraction, therefore this will be absent in atrial fibrillation. Because atrial fibrillation there is no atrial contraction, so it will be absent. Now this can be huge wave, huge A wave, will be seen in case of tricuspid stenosis, because there will be stenosis tricuspid, so atrium has to work more, so more contractility, more will be the A wave, the tricuspid stenosis. Secondly, pulmonary artery hypertension. In pulmonary artery hypertension, right atrium has to work against a more pressure area. Third, in case of right atrium thrombus, in case of right atrium thrombus, again the pressure will increase, just not because of the right atrium contraction but also because of the thrombus. So in these areas you will see a huge A wave. Now there are certain things which is known as Canon A wave. So what is Canon A wave? Canon A wave is, these are very large A wave and which are seen in certain conditions. For example, if this is right atrium, this is right ventricle, and a person developed third degree heart block. So now ventricle and right atrium, both right atrium, right ventricle will contract independent of each other. And there may be chances that right atrium and right ventricle will be contracting at the same time. So there will be a gush of blood in the right atrium. And that will lead to that will cause a very high pressure in the right atrium, due to which a large Canon A wave is seen. So one of the cause for a Canon A wave is a third degree heart block, because of which right atrium and right ventricle contract independently. Other causes are premature ventricle contraction. In this also, an atrium and ventricle can contract simultaneously. then premature atrial contraction, and also ventricular tachycardia. So you have to know these four causes, because in these four causes we can have a, so third degree heart block, premature ventricular contraction, premature atrial contraction, and ventricular tachycardia all can cause Canon A wave. But characteristically, Canon A wave is seen in tertiary block or complete heart block. So this was regarding the A wave. So first we have on ECG P wave followed by A wave, and then we have the first heart sound. Okay, this is the order. Sometimes they ask the order, that is P wave in ECG, A wave in JVP, and the first heart sound. Uh, we have to keep them in order. The order is first the P wave, then on the ECG, then A wave on the JVP, and then the first heart sound. So this was regarding the A wave. Now, after knowing A wave, we have to understand what is C wave. Other way we have to see. So this is A wave, C wave, A wave, A wave, C wave, V wave, X descent, and Y descent. Now coming to C wave. The C wave is actually when we have a right atrium and right ventricle. So when right ventricle contract, this tricuspid valve closes and it moves in the right atrium, due to which there is increased pressure in the right atrium, which is known as the C wave. So C wave is respond to the cross bulging of the tricuspid valve during right ventricle contraction. This tricuspid valve closes and moves towards the right atrium, and due to which the pressure in the right atrium is increased. That is called as the C wave. This is now after this is X descent. That means there is a drop in pressure. Drop in pressure. Now, so now initially what happens, that right ventricle contracts, so the tricuspid valve bulge closes and bulges in the right atrium, and the pressure in the right atrium increases, which is known as the C wave. After that, right ventricle contract further and aorta opens, and due to which the blood moves out from the aorta, and this tricuspid valve moves away from the atrium, and there is a fall in the pressure of the atrium. This is known as the X descent. So X descent is the decrease in the pressure of the atrium because of the right ventricle contraction, leading to the opening of the aortic wall and leading to the movement of blood outside the right ventricle. Now, understand, if during this process there is some TR, that is tricuspid regurgitation, then some blood will also be going from right ventricle to the right atrium. So the fall in pressure that we are expecting will not be there, and thus there will be no X descent. This is very important to understand. And in this case, there will be no X descent. So there will be a CV wave. So we'll call it that a CV wave. That is CV wave is formed in TR. So understand that X descent will be absent. Okay. So you have to remember a formula, that is pay tax. That is T for tamponade X. In case of tamponade, X descent is prominent, and X descent is absent in cases of TR. Okay. Now pericarditis. In cases of pericarditis, Y descent is prominent. This you have to understand. So pay tax means that is cases of pericarditis, there will be a prominent Y descent. In cases of the tamponade, there will be prominent X descent, and there will be absent X descent in cases of the TR. So we will see a CV wave. So we have seen till here. I think you are understanding JVP very clearly. Now if you know JVP by this much, you can almost solve every question of the JVP. So this is the A, C, V, and the X descent and the Y descent. Now we were on the X. So X is created So this is right atrium, this is right ventricle. So now when C wave is created when the tricuspid wall moves to the right atrium during isovolumetric contraction, and there is a decreased pressure, and then after that when the right ventricle contract, aorta opens, blood comes out from the right ventricle, so pressure is decreased, tricuspid wall moves towards the right ventricle, and there is a decrease in pressure in the right atrium, which is called as the X descent. But if there is a TR, so that TR will lead to the movement of blood during this time from the right ventricle to the right atrium, and thus X will be absent. So in TR we will have a CV wave. Now coming to the V wave. So X, in X there are two questions are asked. Prominent X, I have told you the formula, pay tax, that is prominent X disease is seen in tamponade, that is cardiac tamponade, and absent X is seen in cases of the TR, that is tricuspid regurgitation. Similarly, prominent Y wave is seen in cases of the pericarditis. Then we'll see that prolonged Y wave is seen in cases of the TS, and absent Y wave is seen in cases of tamponade. So I will club all those things. Now what is V? V is for venous. So it is through the venous pooling atrium is filled. So there is increased pressure which is known as the V wave. So it is venous pooling leading to filling of the atria is called as the V wave. Now Y descent. Now Y descent is what? If this is our right atrium, this is our right ventricle. So initial 70% of the right ventricle is filled by the right atrium due to gravity. That is called as the fast filling. That is called as the, due to which the pressure in the right atrium decreases. That is called as the Y descent. Now, Y descent can be absent. Now we have to understand something. For example, in case of the tricuspid stenosis, this blood will come slowly from right atrium to right ventricle. So there will be prolonged Y descent. So in tricuspid stenosis, you have a prolonged Y descent. This is the first thing you have to understand. Why? Because the blood will be coming slowly. Now, we have a prominent Y descent is seen pericarditis. Constructive pericarditis, you will have a prominent Y wave. Okay. And then, so after knowing these things, we can now combine the things. So you remember the formula, pay tax. So for X, that is prominent X wave, you see where? Tamponade. This is the first question you see. Also remember here there is absent Y wave. So in tamponade you have a prominent X wave and absent Y wave. This is question is asked so many times. In case of tamponade, we have a prominent X wave, but we have a minus Y waves. Okay. Then we have a question that is absent X waves. Absent X wave is seen in TR, due to which there is a CV wave. This was our question. This is the CV wave because of absent X wave. So this is the first thing. Through tax, we remember that is prominent X is seen in case of tamponade. So tamponade has no Y descent. So that is absent Y. So in tamponade, you have to remember that is there is prominent X wave, there is no Y waves. And second, you have to remember that there is absent X wave in case of TR. So we see CV waves. Now coming to the pay part. Pay part is that is prominent Y wave is seen in case of pericarditis. Then prolonged Y wave is seen in cases of tricuspid stenosis, because I have told you that there will be slowly filling of the right ventricle from the right atrium during the initial phase when right ventricle is getting filled by right atrium due to gravity. And then absent Y waves we have already discussed in tamponade. So I think this tamponade question can come. That is, in tamponade, there is prominent X and minus Y waves. Absent X wave, TR, what we get CV waves. In pay, that is prominent Y wave in pericarditis. Then we get prolonged Y wave we see in cases of tricuspid stenosis, and absent Y wave in tamponade. So this is the thing that covers today's discussion, and I'll come with other questions also.